Welcome to Ask Syd, the official podcast for Sydenham Clinic. Today I come to you from our flagship location here in Beverly Hills. I am so thrilled to bring different guests onto the podcast so that we can talk more about our 7 pillars of health, and we can go deeper into your genomics, your gut health, your hormones, your sleep, your nutrition, psychology and physiology. So let's bring it on. Welcome back to Ask Syd. Today's episode is a very special one. It's our liver edition. And we have one of the top hepatologists in Houston, Texas with us today, Dr. Victor Ankoma-Sey. Thank you so much for joining us.
Thank you very much.
And our very own Dr. Adam Brittain.
Nice to be here again.
Liver is the detox CEO of our body. By far, one of the most important organs we have. Dr. Ankoma-Sey, would you like to start by telling us a little bit about yourself?
Sure. My name is Victor Ankoma-Sey. I'm a transplant hepatologist and gastroenterologist and also trained in internal medicine. I'm the director of the liver transplant program at Methodist Hospital and also director of my private practice, Liver Associates of Texas, also in the medical center. I trained in liver diseases at the University of California, San Francisco, and moved to Texas about 30 years ago. I came running very quickly, as they say. You got to get to Texas as quick as possible. And I've been here with my family for the past 30 years, practicing in the medical center with a satellite office in Pearland and Bel Air.
Well, we're very lucky to have you.
If I could say a few words about my friend Victor. Victor and I have known each other for years, and he won't say this, but I will. He's one of the top hepatologists in the entire world. People will come see him from all over just for consultation. So we're thrilled to have him. Victor, it's great to see you again, and my dear friend, and thank you for being here.
That's very kind, Adam. Those really exceed my expectations, but thank you very much for those kind words.
Well, yeah. If I can request you to please start off by really explaining what is the liver responsible for and what kind of liver ailments can we get?
Sure. The liver is a major organ of the body. In fact, I think it's the most vital organ in that it does a lot of processes. It really helps you metabolize various compounds that get through your body, detoxifies them. It's almost like a detox center that cleanses your blood of toxins. It also helps you in terms of metabolism of food substances. So the energy that you require, part of it is stored in the liver, so it's also a storage organ. It utilizes the storage forms of fuel in your body to give you energy. We call those maybe carbohydrates like glycogen that's stored in the liver and releases energy to help sustain you. It also stores fats and vitamins. It really is a very multi-purpose organ that really serve the needs of the individual for them to be alive, basically. And in terms of diseases that can affect the liver, toxins can do that, including alcohol, excessive alcohol use. Viruses could infect the liver, hepatitis B, hepatitis C. Genetic diseases can affect the liver, thinking of iron overload like hemochromatosis or copper overload, and genetically diseased liver called Wilson's disease. You could also have your immune system attacking the liver with term autoimmune hepatitis. But by far the most common is fatty liver disease, where fat gets laid up in the liver and causes the liver to dysfunction. And that, if untreated or if you don't reverse your lifestyle and act on it, it could lead on to cirrhosis, which is excessive scarring in the liver. And that could lead to liver failure or even liver cancer, in which case you might be needing a transplant if you get into those dire situations. So in terms of lifestyle changes, that's quite important when it comes to fatty liver disease.
That's a great segue into what we do here at Sydenham. It's all about metabolic health, Victor, and hyperlipidemia, poor glycemic control. These all play into liver health, and liver can only take so much toxin load, so much metabolic load. Sure. So increasing that load puts more stress on the liver. That's why our metabolically unfit patients really, if they can reverse some of their lifestyle changes, can really see reversal of some of that fatty change. Now, it's important to know once you get into the fibrosis area, which is further on down the line, then that's not so much reversible. Then we're talking about cirrhosis. So we want to try to avoid that.
Very true.
That depth of inflammation. So if we can get these patients early and make these changes early, cut down on the alcohol certainly, but on the non-alcoholic fatty liver disease, control the cholesterol, control the A1C, making sure they're not becoming insulin resistant, things of this nature.
Very important.
It plays very, very strongly into what we do here at this clinic.
Very good. Yeah.
You spoke about non-alcoholic fatty liver disease. Almost 25 to 30% of the world has non-alcoholic fatty liver disease.
Very true.
And it's even prevalent in people who do not drink alcohol. How prevalent is non-alcoholic fatty liver disease in your practice, Dr. Brittain?
Oh, it's quite prevalent. And a lot of folks, we don't even know that they have it. And how we know, we see some derangements in their liver enzymes sometimes. But most of the time we do the ultrasounds and to look at the topography of the liver, and that gives us an idea of what's going on. Now, if someone has a certain lifestyle, if they do have high cholesterol, if they do have insulin resistance, those people are more susceptible to this type of thing. But we have to look a little bit deeper with imaging and things like that to really diagnose it. But sometimes it goes unnoticed. So a lot of folks at this clinic probably have it, but don't even realize it.
Because most of our members are healthy people, right? So
Most
they
are,
would
yeah.
never land up in Dr. Victor Ankoma-Sey's office until it's too late, probably, right?
Right. You catch these people early, you can really make an appreciable difference in the outcomes. Victor knows this, and I know this. Two different types of patients between this clinic and we see at the hospital. We see very sick people at the hospital, and those folks often in the cirrhotic range and have that fibrosis already set in, and at that point it's hard to make an improvement.
Sure.
Dr. Ankoma-Sey, can you explain to our viewers what is non-alcoholic fatty liver disease?
Sure. So non-alcoholic fatty liver disease, I think my good friend Adam has already mentioned that it's usually caused by what we call metabolic syndrome. Metabolic syndrome is a group of illnesses that predispose you to insulin resistance and allows your liver to load up with fat. The most important risk factor for fatty liver disease is diabetes. So if your hemoglobin A1C, which is a marker of diabetes or insulin resistance, is not controlled, you have a high chance of having fat buildup in your liver, causing non-alcoholic fatty liver disease. The other concern is if you have high cholesterol, which is part of the metabolic syndrome. Hyperlipidemia or high cholesterol could also allow you to load up fat in your liver, contributing to non-alcoholic fatty liver disease. And hypertension or having abdominal obesity, if you are a big around the mid-rib, mid area, your abdomen, it has a lot of fat. That's not a good type of fat that can predispose you to insulin resistance and allows you to load up quite a bit of fat in your liver. So one of the things that Dr. Adam does in his clinic is to measure your circumference of your abdomen. If you have a big girth, that puts you at risk of having fatty liver disease and insulin resistance. And high blood pressure, as I mentioned, is also another metabolic disease that can predispose you to fatty liver disease. So this occurs in someone typically not drinking any alcohol or very small amounts of alcohol who develops fatty liver disease. And we call it non-alcoholic fatty liver disease. There are patients who drink alcohol that also can predispose you to fatty liver disease, but that's alcohol-induced. So we call that alcoholic fatty liver disease or alcohol-induced fatty liver disease. Very similar in terms of a liver biopsy, but the way you get the fatty liver disease is very different. One is being metabolic unsound, as Dr. Brittain mentioned. That loads up your liver with fat, you get insulin resistance, and you're at risk of cirrhosis, just like someone drinking. But it's non-alcoholic fatty liver disease, very common end result if it's untreated.
Can you explain what cirrhosis is?
Cirrhosis is when you have extensive scarring of fibrosis in the liver. Just think about it. When you cut yourself on your hand, you heal by forming scar tissue. So you could imagine fat buildup in your liver, irritating the liver, and the body's repair mechanism is to allow your body to form scar tissue in the liver to try and ameliorate that fatty irritation of your liver. So if that goes unchecked, you have extensive scarring, we call fibrosis, and the end stage is what we call cirrhosis. So when you have extensive scarring called fibrosis, it leads to cirrhosis.
Yeah, that's a very interesting point. Inflammation is the basis of all disease.
Very
and
true.
if that rate of inflammation supersedes cell repair, cell turnover, that's when we get this scarring. But that's the body's natural way of trying to heal itself, right,
Yes,
doctor?
very much so.
So it's just when it's trying to heal itself too frequently and too often, and the rate, I guess it gets too great.
Yeah.
That's when you have that development of a fibrosis and that irreversible form of liver.
Yeah.
Dr. Brittain, how do you catch it early? Because we do a lot of extensive testing on our members. It's all included in the membership. It's preventive testing. What are some of the tests that you perform? How do you catch it early?
Certainly a detailed physical and history is important. Finding out their alcohol intake, the quantity, the amount they're taking in. But if that aside, looking at, as Dr. Ankoma-Sey clearly stated, metabolic health. If there's someone who's in poor metabolic health, I'd be more suspicious of something like that. Sometimes you'll get elevations in liver enzymes, sometimes not. It just depends. Now, quite often you may not get any bilirubin or INR changes, things that we use to measure liver function, change until later on in the disease process. So oftentimes it goes unchecked, and it's hard to diagnose sometimes. But it's easy on imaging because they can see the topography changes. But you may not jump to imaging right away because you may not be expecting to see anything. So it can go unchecked, but if you have enough information about the patient's history and about the patient's predispositions, you can certainly make some educated guesses on what may be going on and then dig deeper and find it that way.
At what point do you refer your patients to Dr. Ankoma-Sey? Of course, our concierge patients, we manage all their sick care. We, coordinate all their care with the specialists. But at what point do you feel like it's important for you to bring him in?
Well, in a perfect world, I'd love to see all my patients who have who have any evidence of any kind of minor liver fatty changes. He sees a lot of sick people that are a lot further down the spectrum of illness. So early in the process, it's all about lifestyle mainly. There are some new medications we'll talk about, maybe a little bit about reversing fatty liver changes, but boy, it's really about the lifestyle early on and making those changes. So I'm hoping not to have to refer anybody to see him. Yeah.
Do you do some advanced testing for diagnosing? Because I know we do all the preventive testing and we catch it, and then.
Yeah, just to emphasize, the first line treatment, as Dr. Adam Brittain mentioned, is a lifestyle change. So that's the bedrock of treatment of anybody with non-alcoholic fatty liver disease, meaning that they have to lose weight and watch their diet. I'm sure we'll speak some more to that later. But the lifestyle change is important. So that'll be the first thing we emphasize. In terms of testing, if that patient comes, they might have had some liver tests, and those liver tests might be abnormal. We'll then go ahead and also exclude other chronic liver diseases, because some of the liver diseases can mimic fatty liver disease. So we want to exclude, for example, viral hepatitis B, hepatitis C, because the liver tests are elevated. We don't want to jump to say that it's just fatty liver disease. We want to exclude other. It's a diagnosis of exclusion.
Do they also coexist?
They could coexist, but the first thing to do is to be sure that you're not missing an autoimmune hepatitis or hepatitis B or C, that the treatment is different than what you tend to recommend for someone who has non-alcoholic fatty liver disease. So once you do that initial panel, you'll be looking for those other diseases that could mimic fatty liver disease because the imaging showed fat buildup in the liver or your liver tests were elevated. When that is done and we've excluded other causes of liver disease, then the next step is to try and stage that patient. You want to find out how severe the liver disease is in terms of the non-alcoholic fatty liver disease. So typically you could do that with blood testing, which is a very good way of doing a first initial screen. There are lab panels that could easily determine the amount of scarring in someone's liver that will put them at high risk of going on to cirrhosis, as opposed to someone who is low risk, who has a very low risk of cirrhosis, in which case lifestyle change will be emphasized for both groups, but the high risk patient would then be referred for potential treatment drug therapy. And the tests that we use include things like FIB4, that's a blood test that's based on some of the regular labs that we do in clinic with Dr. Adam's patients. And you put it in their smartphone app. It's a formula which will spit up whether you're high risk or low risk. There are other blood tests that you can do that will also tell you about the amount of scar tissue of fibrosis that patient might have, whether they're headed towards cirrhosis or they're very low risk with almost no scar tissue and only inflammation. One of them is called the ELF score, an enhanced liver fibrosis score. It's a test that's done by regular labs, including your labs. Quest or LabCorp could do that. And that would again stratify that patient into high risk or low risk. You could also use imaging, which if you don't have that facility, might be a bit difficult to get access to. In our clinic, we have what we call a fibroscan. A fibroscan is a special type of ultrasound that measures the stiffness or scarring in your liver. It takes about 5 minutes. It's non-invasive. So it's actually very appealing, just like the blood test. You don't have to do a liver biopsy. The ultimate test would be a liver biopsy. All of us shy away from liver biopsy, including patients. They don't want to be poked with a needle to find out how their liver is doing. So the non-invasive testing is the way to go, including blood tests or imaging. One of them is called the fibroscan. If you want more precise imaging, you could then go ahead and do what we call an MRE, magnetic resonance elastography, where an MRI looks at the liver and tells you how much scar tissue there is in your liver. Again, it being non-invasive, is very precise, almost as good as a liver biopsy. And so the MRI has features where they would measure the amount of fat build up in your liver. Apart from the scarring, which you tell about fibrosis, you can measure the amount of fat build up with the fibroscan and with also the MRI. The MRI fat buildup is a special MRI called MRI PDFF, protein density fraction, fat fraction. So that measures the amount of fat buildup in your liver. With the PDFF, it's very precise, whilst the elastography measures the stiffness or the scarring in your liver. So you want to go away from that patient having two major characteristics being defined for that patient: the amount of fat, plain fat in the liver, and the amount of scar tissue or fibrosis in the liver. Because that would then determine how you treat that patient.
Now there will be a test on this.
Okay, sure.
What's the difference between MRI and MRE?
There you go. There you go.
So there are a lot of cutting edge testing that's available to, after we catch it early so that you can stage it. And let's dive into some of the treatment side. And I see the importance of tag teaming with a great primary care longevity clinic like ours so that you can manage the lifestyle changes as well as the other comorbidities or other factors that are affecting it.
Sure. Certainly.
Yeah. Doctor, yes. Please, go ahead.
Okay, sure.
Yeah,
I'll take the lead and then I'll follow.
I'll say what we do on a baseline level in terms of diet and exercise and cholesterol control, and then I'll hand off you to the more advanced, some of the new biologics that are out there maybe. But yeah, no, I think it starts with me all about metabolic health. Blood pressure control, as Dr. Ankoma-Sey mentioned, LDL cholesterol levels. We want to get that down. If the patient has a history of heart disease, certainly 70 is our goal. Sometimes we don't get there. Sometimes it's just below 100. But certainly controlling that, making sure the exercise, the sleep, all the aspects that can, if you've got sleep apnea, increased cortisol release is going to increase visceral fat, is going to increase blood pressure. All these things play into your metabolic health. I'm a big proponent of a keto-based diet, high protein, low carbohydrates, good, solid monounsaturated, polyunsaturated fats, where you train the body to burn fat over carbs. You may not know this, Dr. Victor, but I'm also a big proponent of cold plunge. Cold water immersion has been shown to decrease visceral fat and also change that white fat into brown fat, which is infused with mitochondria. So all these things play a role into increasing one's metabolic health. So I optimize these folks as best I can.
Good.
And if there needs to be more fine tuning, then Dr. Ankoma-Sey will take over and do some of the more advanced therapeutics and things like that. He may want to mention some of those.
Yes, I really endorse that the first line treatment for fatty liver disease, non-alcoholic fatty liver disease, is lifestyle. So weight reduction, metabolic health, as Dr. Brittain has outlined, is critical, is very key. That should be your number one go-to. In terms of medication, that's secondary. That if someone, we stratify them or do further testing and they have significant scarring or fibrosis, then we would start thinking about medications that can protect them from progressing on to cirrhosis. And so once someone comes to us and we've done either a fibroscan or ELF test or MRE, we'll be able to tell how much scar tissue that patient has, because the scar tissue is the main driver of progression of that patient to cirrhosis. So these tests will be able to categorize the patients into different types of fibrosis. No fibrosis, which is the normal healthy liver, is called F0. Mild scarring or mild fibrosis is F1. Moderate scarring is F2. Severe scarring is F3. And guess what? Cirrhosis is F4.
They have really followed the racing terminology.
Oh, definitely, yes. 1 to 4. So in one way or the other, whether you're using the fibroscan of MRE or ELF test, you'll be able to stratify your patient whether they have F0, F1, F2, F3. And the sweet spot that you really want to intervene in terms of medications and other therapeutics is when they're between F2 to F3. And that's what the FDA has actually approved drugs to be used. So not for F4 yet, but if you're F2 to F3, which is in terms of thinking about the patient, very preventative, and you're actually talking about longevity, which you're a big proponent of, you've done a wonderful job with that in your clinic, is to treat those patients who are F2 to F3 with both lifestyle and drugs to protect them from going to F4 and needing a transplant down the road. F0 to F1 is lifestyle changes because they don't have adequate scarring or severe scarring. Lifestyle change should be the way to go, and hopefully you reverse them even further. So F0 to F1, F1 to F2 is lifestyle change alone. F2 to F3 is lifestyle change with medications. And if you bear with me, the medications that have been approved for fatty liver disease, non-alcoholic fatty liver disease, F2 to F3, Resdefra, which is a drug that defats the liver literally and gets the liver to repair itself. They've done extensive studies that have shown that this is very effective in improving inflammation in the liver and also reversing early scarring. So you could have someone with F3, a lot of scarring, being treated with lifestyle change and medications going to F2 and possibly to F1. And that's a good reversal, and it's life-saving. The second agent that just got approved a few weeks ago is the GLP-1 agonist. Wegovy has also been approved to be used to treat patients with non-alcoholic fatty liver disease, F2 to F3 again. So you have to be F2 to F3 to qualify. And of course, you want to manage the metabolic risk factors, diabetes, as Dr. Adam Brittain mentioned, your cholesterol, your high blood pressure, all has to be fixed. Your stress level, good sleep hygiene, sleep apnea. You want to work on all that to put you in a good spot. But if you have to do medication, it has to be F2 to F3 who would qualify to be treated with meds. So I hope that explains.
Interesting. We have a lot of patients on GLP-1s.
Oh, wonderful.
And
yes.
I guess the mechanism is the same across the board. It just certainly slows the emptying of the stomach, increases metabolic health through decreased calories, more than likely, and decreased fat storage in the form of triglycerides and cholesterol. So very interesting.
Yes.
And that first medication you mentioned, is that a biologic or is that a what's the mechanism of action?
It's actually an oral agent that works on the mitochondria and fat metabolism in the liver.
Okay.
It works on a thyroid receptor. There are thyroid hormone receptors. One of them is beta agonist 1. That's been shown to be very important in metabolism of fat in the liver. And this is very specific and targeted to that receptor. And it really gets the fatty liver to repair itself.
Right.
Takes out the bad fat from the liver. So it's almost a defatting agent and is very targeted to the liver that does its job.
Very interesting that it's a mitochondrial specific type thing, because we stress mitochondrial health here at the clinic, and that's one way to really improve inflammatory responses, keeping the mitochondria healthy. Because once the mitochondria becomes sick or injured through that inner membrane with free radicals, then you get the distress signals into the immune system that lays down the inflammatory response. So if you can target that mitophagy or that mitochondrial turnover, you can, and site-specific, organ-specific, you can really make a difference in the health of that tissue.
And that's what Resdefra does, is very specific to the liver and targets that organ. And I think questions that come up is whether you can use both together. Of course, if you have someone who's maybe obese or has diabetes who needs the GLP-1 and they happen to have fatty liver disease, you could do that and also add on your Resdefra. I think the trick is to use one initially, make sure that it's well tolerated before you add on another drug, but both of them would really help that patient.
Very interesting.
Interesting. So we are in an exciting era. Hopefully with the advent of GLP-1s, we can see this incidence of non-alcoholic fatty liver disease come down.
Yes.
I would like to switch gears now. And Dr. Brittain, could you also explain to us why the liver is an important organ and how is it related to our 7 pillars from a longevity perspective?
Well, detoxification, as Dr. Ankoma-Sey mentioned, it's the main detoxifier. It keeps us safe from toxic chemicals and biologic toxins, environmental toxins, certainly through different conjugation systems, phase 2, phase 1. We can get into specifics. It's a little detailed. But, those types of detoxification, energy metabolism in terms of glycogen release certainly is a huge part. Metabolic syndromes that helps predict those types of things. Hormone regulation is a big one that it's also involved with. So it's almost like the main gatekeeper of the body. If you have problems with the liver, you're going to have problems with most other organ systems. And we see patients at the hospital, very sick patients. Once they develop liver failure, then most other organs kind of follow suit. So we know that the organ is kind of the headmaster of the body, as Dr. Ankoma-Sey mentioned so eloquently at the beginning of the lecture. So that's how it plays into longevity. If you don't take care of your liver, you can't have longevity. I often give the health connection lecture to my patients a lot. You can't have wealth in the bank, money in the bank, without your health, right? If I know a lot of wealthy people who are sick, they have one wish, and that's to be healthy. If they're healthy, they've got lots of wishes. We know some of the same patients that think that way. So you can't have health and longevity without the health of the liver, and keeping that organ healthy throughout the entirety of your life is imperative. And doing the things that we talked about today is how you do it.
And the good part is the liver can regenerate itself. So fatty liver disease is reversible.
Yes.
But once you break that threshold of fibrosis, then it becomes less. So it's important, early detection, making changes early is imperative.
Right.
Yeah.
So before we jump into our very spicy, rapid fire, hot or not section, Dr. Ankoma-Sey, would you share with us some of maybe one health trend that you really support?
Sure. I think it's actually been mentioned by Adam earlier, is diet. Yeah, there's been a push. I see a lot more people embracing ketogenic diet, low carb diet, and Mediterranean diet. I think if they have to do something on diet, those are the two things. Mediterranean, because of the good cardiovascular health you get from that, and a ketogenic low carb diet. And I think that's a healthy trend that I fully support.
Yeah, you really teach the body to burn fat over carbs. And that's it's shown in epileptics and certain brain conditions to be very, very beneficial. And certainly in terms of overall metabolic health and visceral fat, certainly. My question, Dr. Ankoma-Sey, is some of the liver detoxes, this is in the biohacking stuff, that are out there on YouTube and stuff, how much the curcumins of the world, the NACs of the world, the milk thistles, a lot of that research is maybe helping people with already some degree of liver disease, but not doing much for people with healthy livers.
Yes, that's very true. I would definitely support that some of them are unproven, and some of them are safe, because, for example, a number of our patients take milk thistle. It's an antioxidant, and it's relatively speaking safe, but you just have to make sure you speak to your physician about it.
That's the right
key,
answer,
and so that you would be monitored. Because you might have a reaction to it that other people might not. They might be okay, but you might have an adverse effect from that particular supplement. So I say definitely discuss that with your physician, Dr. Adam, or any of your family doctors that you want to run it by them, and then they could guide you as to what you should do. But again, if you're really looking for specific therapy for fatty liver disease, we have very good specific therapies that I've mentioned. So you could discuss that with your doctors, and they would actually direct you to those therapies, which has been proven to be effective. They have a good safety profile, and you'll be monitored whilst you have getting those treatments that you do well.
Right.
Well, thank you so much for sharing that. Dr. Brittain, would you like to add anything?
No, we're just thrilled to have you here. Thank you for your expertise, and it's been great to have.
Let's dive right into our hot or not liver edition. So, Dr. Ankoma-Sey, hot or not, drinking alcohol in moderation?
Moderation is the key. Very little alcohol. There's been a push against, initially we thought alcohol was a panacea for everything, but it has to be in moderation.
So it's
A
not.
lot of our patients think it's the panacea. That's for sure.
Yeah.
I think in moderation is right. I would say any alcohol is going to have some stress on the liver, so that's why we're kind of backing away from, condoning because telling someone one glass of wine is okay, then that leads to 3 or 4, and so.
Totally not hot. Dr. Brittain, what about after party or after drinking pills? Hot or not?
No way. Not unproven. It's not going to help you. It may actually do more harm than good. The take-home message is don't put yourself in that situation in the first place. And your liver will thank you the next morning without taking any supplements.
Yes.
Dr. Brittain, again for you. Turmeric shots for liver detox.
I think turmeric has some interesting evidence, but again, it's only for people who have a little bit of liver disease. It's a huge anti-inflammatory. A lot of the evidence is on orthopedic types of responses to turmeric, but I think that there's no, as Dr. Ankoma-Sey, it's safe. It's not really followed by the FDA, so it's going to be pretty safe across the board to take. It's not going to harm you. And the turmeric root has long been used as an anti-inflammatory. So I think initially it may help a little bit. It wouldn't do any harm.
So can we classify turmeric shots as hot?
I would say hot, sure, why not? just to spice it up a little bit.
Dr. Ankoma-Sey, what do you feel about intermittent fasting, hot or not?
I think hot, good.
Yeah.
Yeah. It's, again, speaking to trying to change your metabolic state to really breaking down fat as a fuel rather than carbohydrates. Intermittent fasting, again, helps. It also decreases the amount of calories you consume, even when you do that. So I think it's something you could do. And if you can tolerate it, it's something I really would promote.
We already spoke about milk thistle. Hot?
Yeah, it's the same with turmeric. I don't think it would do any harm. I think there's evidence it may push some toxins out, but the liver does that anyway. So I'm kind of in the middle on that one.
Hot?
I think there's some antioxidant effects, but again, it's not the big gun you reach out for when you have serious liver problems.
Right.
Apple cider vinegar shots.
Boy, not too familiar with much of that. I would say it may slow emptying of the stomach, and it may do some of the things that the GLP-1s may do on a less of a level, but I would say indifferent on that one. Probably not. I would say probably not. Not hot. Yeah.
Detox juices.
Same kind of thing. It's going to have turmeric in there. It's going to have N-acetylcysteine probably, and milk thistle. They're all the same. They just have different advertisements and marketing ploys. So just if you do those things, make sure you read the ingredients, make sure you check with your physician. That's the most important thing. Like Dr. Ankoma-Sey mentioned, is the most important to do.
It could be quite misleading, I think.
It can be, especially with all the biohacking and stuff. You got to make sure again, we don't do anything that's not science-based. So everything that I do with my patients is based in science. So just make sure you speak with your physician before you.
So not much evidence behind detox juices.
And someone comes in with evidence of fatty changes, you don't want to just promote these things, telling them that's going to fix their problem, when we have someone like Victor who can really dive deeper and do the real science behind the treatments.
What about NAD plus supplements or injections?
I think NAD is interesting. We know it's the rate limiting step for energy metabolism as we get older. So I think a lot of my patients benefit from NAD, whether it be oral or injection. In terms of liver health, I think all cells in the body are very similar in terms of energy metabolism, how they produce ATP. So I think if you're deficient in intracellular NAD, it could possibly benefit and increase longevity of the cell, certainly.
I think the data suggests that if you're deficient, it could help quite a bit. So I agree with you, Adam.
And people who are deficient, I've got a patient who he had a number of 17. He was very, very low. and put him on a NMN supplement with some resveratrol, and he was up to 34 within a month, back in the gym doing things.
Doing stuff, yeah.
So yeah, they can tell a difference in their energy levels.
Well, thank you. Today's been a really fascinating podcast for one reason, because our traditional healthcare system is so focused on sick care. And very reactive. And this is what needs to happen. You know, your preventive care doctor, your internal medicine doctor needs to work closely with specialists like you. You know, it's not, a lot of time, you know, physicians will palm off a patient to you. And some of what Dr. Brittain is doing falls into your lap. And that could become very hard.
I think it should be a partnership where Dr. Brittain sees a patient and I work with him to the benefit of the patient, and still would see the patient on a more regular basis just to really promote longevity and good health, a good liver health.
And I've sent you a couple of patients,
definitely,
and they're just so pleased with everything. And just having that reassurance, I think, is a lot of what we do as well. You know, someone with some fatty liver changes, you reassure them that we're at a low stage of transformation into cirrhosis, so we're still early enough where we can make the changes. And the gentleman I'm thinking of has made changes, and I'm anxious to see what his results are, because he's feeling a lot better, more energized, and I'm sure he's going to have improved results on his testing. So.
And this follow-up, measuring, constantly seeing the changes is very, very rewarding. You know, it's very rewarding at Sydenham,
and it actually reinforces the patient's positive, good behavior, because they know they made this change based on what Dr. Brittain told them, and they've seen this change. This number has gotten better. Wow, I'm doing the right thing. I got to continue. So it's really a motivator.
No, and we have a full-time clinical nutritionist who works with all our members, and she supports all our physicians, and nutrition plays a very, very big role as far as liver health is concerned. But thank you again for today's podcast. It has been a pleasure to host the two of you. Some very encouraging information. So let's endeavor to keep our healthy liver for a healthy life. Thank you so much. If you need any membership information, or you're intrigued to become a Sydenham member, you would like Dr. Brittain to be your doctor, just log on to our website, www.sydenhamclinic.com. You can also follow us on social media. Until next time, keep sending us questions on our podcast, Ask Syd. Thank you.